So we're going to talk about diabetes. So diabetes is a dysfunction of our pancreas and a dysfunction of our cells' response to insulin. In case we either don't make enough insulin, the insulin we make doesn't actually do anything, or our cells are not receptive to the insulin that our bodies are making. Okay, it's the leading cause of death from disease, and that's because it leads to cardiovascular disease. And we're going to talk about the two different types, so type 1 and type 2. So type 1, again, is going to be a pancreas dysfunction. So type 1 is the complete lack of insulin. Okay, it's not that our cells aren't receptive of it, which type 1s can develop insulin resistance, but it's because our pancreas is not making any insulin. Okay. Used to be called juvenile diabetes because we often would see it in younger populations. There is a genetic component, so often if you have like a first-degree relative, that increases your chances of developing type 1. Immunologic, so autoimmune disorders, and then they're seeing a lot now environmental exposures, such as viruses, so like measles can cause type 1 diabetes, and other common childhood illnesses. And then these guys need supplemental insulin just to survive. Without supplemental insulin, they're not able to use glucose appropriately and they will die. And then type 2 is when we have either insufficient insulin production, which we can see because our pancreas is burnt out, and that can be a result of consistent hyperglycemia, often related to diet and lifestyle, right? So not only is this from foods that are high in sugar and glucose and carbs and fat, right? We need all of those, all eventually get converted into glucose. Our bodies still think we're peasants and need to store all that sugar somewhere. We store it in our liver, store it as adipose tissue, right? And in order to store it, we need to make lots and lots of insulin. So our pancreas gets burnt out, starts making less insulin. Or we develop insulin resistance, where the insulin we do make doesn't fit into the holes of our cells, right? Our lock or our key is the same, but our locks have changed because our cell shapes have changed. And that's insulin resistance. And so these are different types of insulins. Just a quick little once over. You're going to want to look at this slide. I like the graphs here that kind of show us. So we've got our rapid acting, which is like our Humalog. So this is what we give before meals. Onset within like 5 to 15 minutes is when it starts working. Peak of 30 minutes, right? Peak is when we're at risk of hypoglycemia. We want to look at our peaks. Okay, short acting or our regular insulin, right? We're going to talk a lot about regular insulin in our emergencies because it's the only one we can give IV. Okay, onset about 30 minutes, peak 2 to 4 hours. Onset IV is going to be quicker than that 30 minutes because it's available right away. And then our NPH, Humulin N, we don't see this as often because this peak is super spooky, right, with being pretty unpredictable. But it's the affordable insulin. When you guys hear like the Affordable Insulin Act, it's not the nice insulin, it's the Humulin N. That's $30. And then our long-acting Levemir is slowly but surely being taken off the market, but we still have like our Lantus that you guys will see, or our Glargine, right? And then that is this no peak, so not as high risk of hypoglycemia. Can cause hypoglycemia, right? It still can, but not as spooky as some of our other ones. So, DKA. So we see this pretty commonly in type 1s, especially when they are initially diagnosed. It can also happen in type 2s. This isn't just a type 1. And what it is we have a complete lack of insulin, okay? And so many things can trigger DKA, such any really like high stress thing that happens to the body. So think of our multiple medical issues such as a MI, all right, PE, if we have surgery, a bleeding, pancreatitis, infection, surgery, all right. Dehydration is a big one that can cause DKA. Non-adherence to our insulin regimen, right? We were able to take our insulin for some reason. We were able to pick it up. We didn't know we needed to take it. We didn't want to take it. Dysfunctions of our insulin pumps, right? Eating disorders, certain psych medications can cause DKA. And the medications in general, such as our beta blockers, right? Beta blockers, some of our more non-selective ones are going to act on the beta cells of our pancreas, which release insulin. Okay, so if they're being blocked, they also release glucagon. Then we're going to have problems there. Our diuretics, right, so are going to increase our risk of dehydration. And our diabetes medications actually are SGLT2s, which is our Farxiga, our Jardiance, which we've seen at the hospital used a lot for heart failure. Okay, it's the gold standard for heart failure. It can cause a euglycemic, so a normal blood sugar, DKA. All right, and so we have an absolute insulin deficiency. Okay, this insulin deficiency does not allow glucose to be moved into the cells. Okay, so we have our bloodstream here, bloodstream, okay, and then these are our glucose crystals, all right, and here's our liver. And our liver is like, bro, I am starving, right? I'm not getting any of this energy. And our liver has glycogen, okay? And so this glycogen is then going to be converted into glucose through glucogenolysis, all right, into our bloodstream as glucose, increasing our blood sugar, okay? And eventually, these glycogen reserves are going to be depleted. So we have high blood sugar, cells, especially the liver, still thinks we're starving, so it's going to keep telling our body, hey, I need more glucose, hey, I need more glucose, hey, I need energy of some sort, right? Please help feed me. And that is when our body is going to say, okay, let's break down some adipose tissue, right? It's going to break down excess cholesterol that we've stored. And then when we run out of that, because those are just little quick energy bites, they're not super helpful, we're also going to break down protein. Okay, so muscles in our body. And the breaking down of that protein is kind of where we get our problems, because these are going to make ketones. Granted, using anything that's not glucose is going to make ketones. Ketones are acidic, so with ketones, we're going to have a drop in our pH. Okay. With the hyperglycemia, all right, this is going to go to our kidneys. Our kidneys are like, wow, this is way too much blood sugar. And it's going to start peeing out all of this excess glucose. And water follows glucose. So then we have an osmotic diuresis. All right, so we're going to be dehydrated. Okay, we're not peeing off enough glucose to fix our blood sugar, right? We're still a little hyperglycemic, but we're dehydrated. And then with the osmosis and the breakdown of muscle cells, right? Our muscle cells have a lot of potassium in them, about 135 millicues. So we're going to have this at first, right? So we can see both. So we can see excess potassium in our bloodstream because of the muscle breakdown, as well as the fact that insulin pushes potassium into our cells. So no insulin means we'll have a higher potassium. We can have a high potassium, or it can be low because we are peeing it all out. Okay. If it's high, it's going to worsen our acidosis because it's a positive ion. And then we are going to also have the ketones, right? So we're diabetic, we're hypoglycemic. We have an acidosis, okay, our pH is less than 7.35. And then we're going to be positive for ketones. And we can measure ketones in the urine because you're going to spill them in your urine. The urine is kind of instruments your plasma, which is pretty cool if we use it to measure things appropriately. And then we can also check specifically in our blood serum or as a point of care test the beta hydroxybutyrate, which is a specific ketone. Our liver makes 3 of them. Okay, your beta hydroxybutyrate is one of the specific ones that we make in DKA, right, resulting in the keto part of our ketoacidosis. Okay. So what are we going to see? So we're going to see the 3 P's: polyphagia, polyuria, polydipsia. Okay, polyphagia, they're hungry. They're eating all of the time because their body is telling them that they are starving. They're not actually starving. Okay, their glucose is high, but none of that energy is actually entering any of their cells, specifically like their brain, right? Your brain can only use glucose. And so your brain is like, we are starving, keep eating, which worsens our blood sugar. Dang it. They're going to be peeing all of the time, polyuria, because of that, diuresis, okay, and then polydipsia, because our serum osmolarity is high, which triggers our thirst response, and your thirst response is pretty significant, right? It's very hard to override being thirsty. This is why people like drink out of the toilets and do wild, crazy things. And then they're also losing all that fluid because of the diuresis. So these are your patients that come in. They're like, I'm diabetic. I was sick with the flu last week. They have like their gallon jug of water. They're nauseous, and you're just like, cool, you're probably in DKA. Let me get my ketone strips. They're going to be tired, fatigued, right? Because they are not getting any energy into their brain. So, going to see some fatigue. We're going to also we could see some intravascular volume depletion. All right, they are dry. So with that, we'll see like poor skin turgor. Okay, we could see hypotension, especially if they're no longer compensating for all of that fluid loss. We're going to see ketosis, and in ketosis, one of the symptoms we might see is, or I guess smell, is this kind of acetone breath, like a sweet acetone smell. So they say like nail polish, the less G-rated version is like 3-day-old like beer or something. That's what it smells like. Very gross. And then they're also obviously going to be acidic. Okay, we can do an ABG. We can also see it on a VBG if they're acidic, right? It's the same, doesn't matter. And then they're going to have Kussmaul respirations. And because of this respiration pattern, right, where they're breathing super, super fast and super, super deep. So they're going, okay, that is blowing off CO2. So they're compensating, right? If we think of our ABGs, okay, when we are in a respiratory acidosis, it's because of a high CO2. So if we blow off all that CO2, it's going to decrease or increase our pH, hopefully, and help balance this metabolic acidosis. And so that's why unless these patients are comatose, we do not intubate them. All right? No machine is going to be able to compensate for their metabolic status quite like their own machine, okay, their own body. All right, give them oxygen if we need to, kind of help support them as we need to, but If they have Kussmaul's and they're awake and they can maintain, even if they're super lethargic, if they're maintaining their airway, if they're breathing on their own, there's not a lot of secretions, their tongue isn't in the way, let them breathe at 40, 50 miles an hour breaths per minute. That's what's keeping them alive. Okay. Diagnostics, so we can do our ketone strips, right? So ketone strips, you can do a dipstick test, which we do with urine. All right, so a little ketone strip, you stick it in the urine, it usually turns like a purple color if there's ketones. Or we can do just like a point of care with the some of like the glucometers have the ability to test for ketones with a certain special strip on them. All right, check our blood glucose level, obviously. Again, check that beta hydroxybutyrate. Depending on where you work, will give you your value. I think your book says 1.5, but at the clinic it's 0.03, and I believe at Benefice it's 3. And then we're going to do a blood gas to see how bad our acidosis is. And so quick here is just a criteria, right? We need to have hyperglycemia. Okay, we need to have acidemia. Bicarb needs to be low. Okay, we can also check our bicarb as our CO2 on just our CMP. All right, so that's why we don't necessarily need an ABG. Positive for ketones. We can check serum osmolality, generally going to be low, and then a wide anion gap. And so you calculate the anion gap, it's going to be sodium minus chloride plus our bicarb. So either our CO2 on our CMP or our bicarb on our blood gas. And that's how you calculate our anion gap. And we have to use a corrected sodium. So for hyperglycemic, it's going to make our sodium appear lower. So you need to use a corrected sodium when we calculate our anion gaps. So treatments, right, in this order. We're rehydrating. We are giving them IV fluids, okay, generally just starting with a liter. Okay, like of some sort of crystalloid, okay, lactate. So LR is the preferred IV fluids. Then we're going to worry about reversing this acidosis. Sodium bicarb only if their pH is less than 7. Okay, so if it is 6.9, we'll consider sodium bicarb. We're going to then worry about our insulin here. Insulin is the last thing I'm worried about. Their hyperglycemia isn't going to kill them first. What will kill them first is the dehydration and their acidosis. So we're fixing those first. Rehydrating. Okay, so we're going to give our liter of fluids. We're going to recheck our labs because once we're hydrated and no longer hemoconcentrated, our labs are going to look a lot different. So we don't want to be treating things the same. Okay, we're going to adjust our potassium, whether we're in that hyperkalemia or hypokalemic state. All right, if we have to replace it, we replace it. If it's high, the insulin's going to help drive it down. Okay, we do not start our insulin until our potassium is 3.3. Again, I don't care what that blood sugar is. Once my K is 3.3, I can start my insulin. So my insulin's going to drive my K down. And then our treatment's always going to involve prevention. Okay, so if we know what caused this, trying to prevent it in the future. And then diabetes sick day education. So patients who are sick and not eating still need to check their blood sugar at least 4 times a day and give themselves insulin accordingly. A lot of times you're like, I'm not eating, so why would I need to do this? Well, again, when we're sick, we have increased cortisol levels, so our blood sugar is going to be higher. We also need to teach them signs and symptoms, right? So once they're noticing that they're thirsty all the time, peeing all the time, super hungry all the time, they need to come in and get checked. They can have ketone strips at home. Check their urine for ketones. Come on in. Not all DKA is severe enough that we have to do an insulin drip. Sometimes we can just do some sub-Q insulin again, correct that fluid status and those electrolytes, and then they can go home. This can be fixed in the emergency room. These patients don't always need to be admitted unless they're complicated or severely acidotic, but this can be fixed in 2 or 3 hours. Okay, they can be corrected by the time we redraw our labs in 4 hours. That's our goal. Okay, have them corrected as quickly as we can so we don't have worse outcomes down the line. You guys got this in SIM as well, and it's just the up-to-date algorithm. There's many algorithms out there of how to treat DKA, but we kind of look right. Fluids, potassium, which is going to be our electrolytes, help with our acidosis, insulin, bicarb, only if we're less than 7. Only if we're less than 7. Otherwise, we don't need it. It's not going to do anything. It's going to make our acidosis worse down the line. Okay. And so we know we're out of DKA. Biggest part is when this anion gap is closed. Okay, you'll hear that they've closed their gap. And it's not on this slide, but we're negative for ketones. Okay, they still might be a little hyperglycemic. That's okay, as long as we're rehydrated and we have fixed our electrolyte abnormalities and our acidosis. All right, so DKA. Okay, you're suspecting DKA. 2 large bore IVs, get your labs off of those. Perfect. Fluids first. Okay, electrolytes. Central lines are preferred. We don't need a central line in DKA. Again, they should be fixed in a couple of hours. It's a big waste of time and money. If we can't get an IV, sure. We don't get a central line just to run our potassium. We can still run 10 milliequivalents in an hour, okay, while giving them, so 10 milliequivalents in an hour, 20 in an hour if it's a central line, all right. CMP, it's annoying, every 2 to 4 hours. All right, they're going to be NPO because if they eat anything, it's going to screw with our insulin drip. It's going to screw with our metabolic demand. NPO. Okay, again, the insulin drip, it's continuous. Okay, your insulin drip is going to be 0.1 units per kg per hour. All right, we're going to start with a 0.1 units per kg bolus, all IV. All of it's IV. All right, and then we're doing hourly capillary blood glucose checks with our neuro checks. Okay. And now we're going to talk about hyperglycemic hyperosmolar syndrome. So this is, we have enough insulin, all right? They're insulin deficient, but they're not insulin depleted. We have enough insulin that they're not in ketosis, okay? So they're not ketotic, but this high glucose levels, these are glucose levels of 500, 600, greater than 1,000, or undetectable at 1,500. Crazy high blood sugars, okay? Their blood is like the gel icing that you use to decorate a cake. That is their blood. Not great for perfusion, as one can imagine. And then, because of these high sugar, kind of the same thought process of our kidneys are like, whoa, we need to get rid of how much glucose? You want me to get rid of, if it was 1,500, you want me to get rid of 1,400 milligrams per deciliter of glucose? Okay, on it. Well, that glucose is going to be excreted and it's going to pull fluid with it. All right, so they're going to be dehydrated. Okay, pretty significant water loss. We can assume like 100 mils per kg of water loss, right? So again, if these patients are diabetic and their blood sugar's that high, they might be a little heavier. So we think about lots of water loss. And then with the diuresis, we're also going to pull our potassium, so electrolyte loss as well. Kind of the same causes. Okay, if we think about infection, acute illness, some medications. And so these guys can come in, they might come in kind of confused, dehydrated, tachycardic, hypotensive, all those good things. So management, we gotta fluid replace them again. Okay, NS, toss some fluids at them, LR, toss some LR at them. correct our electrolyte imbalances if we need to. So if they're hyperkalemic, we can give the insulin will help that, and if they're low, we'll give them potassium. And then same thing, we'll put them on the same insulin drip as we use for DKA. Try and get their blood sugar less than 250, and then we can start sub-Q insulin. And that's the same with DKAs. Once they're less than 250, less than 200, depends on your facility's protocol. But once they're closer to normal glycemia, we will give them sub-Q regular insulin, which is then when we need to know when our onset is. Okay, about 30 to 60 minutes. So then we turn off our drip after 30 to 60 minutes. Otherwise, we're not getting any insulin in that time. And just here's a nice little comparison of HHS and DK. This would be good to study. This just means that there's sugar in the urine, obviously, because of the osmotic diuresis.